Well, good evening, everybody. Welcome to this week's Maternity and Midwifery Hour. This is session 7 of series 13. My name's Sue Macdonald. I'm the curator for the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour, and it's my pleasure to be chairing this evening's session, and I'm delighted to be joined by Lyn Jones this evening, because we've set her a real good challenge to do records and notes and all that malarkey that we all take for granted and yet find quite difficult. But before we start, we're going to ask Lynn to share a moment of the week, because we always do, just to share something nice that's happened, Lynn. I hope you have had something nice happen.
I have had something nice
Good.
happen. Yes. I spent some time with my youngest two grandchildren, so that was lovely. So I don't get to see them as much as I would like to see them.
Wow. Well, that's a good moment. So was that the weekend?
No, that was Tuesday. I think I went Tuesday.
Tuesday.
Yeah, Tuesday
Tuesday.
morning. This weekend I'm spending with my all of my children and all of my grandchildren at Centre Parks. So
Oh my word, that's
it's a
going to
it's
be
a
a bit
delayed
mad.
60th because I was 60 back in lockdown. So
Oh wow. Oh, that's
yes.
fantastic. Well, that's going to be real fun, isn't it? A
It
real
is. It's taken us
celebration.
4 years to get everybody together.
Yes. And that's a cue for me to just remind people where the maternity hour came from, because that's my cue for this time at the moment. Because of course, the maternity hour started right at the beginning of the first UK lockdown in March 2020. I can't believe this is 4 years ago now. And the maternity hour is really a response to that, because we were very aware that midwives, student midwives, people in maternity care generally, and that was our focus, of course, couldn't attend study days, couldn't attend festivals, couldn't attend conferences, and they needed some connection plus some information. And of course, at that time, the information people really wanted was about COVID-19, about how services were coping, the things that people were doing to kind of manage their whole system and maternity services and education. And we spent a lot of time sharing a lot of the innovations that midwives were doing at that time. Some innovations we've kept, including the maternity hour, and others have kind of gone along the wayside. And I think we could reflect on some of that, because some of those innovations, and I was talking to some midwives at my local trust about having the wobble room. Does anyone remember the wobble room? That was that was the place you could go when you were having a bad day, you were very tired, maybe you'd been wearing a load of PPA, which everyone was wearing at that time, and you just needed time out, have a cup of tea, just quiet time. But of course, those rooms all seem to have vanished, and my local trust didn't seem to know what had happened. I think it'd been taken over and turned into an office. But I think it'd be worth thinking about having that sort of thing back again, because now we've got different stresses, but we still need to be looked after and be able to look after ourselves as well. And that sort of strategy does help us. So I'm going to give people homework to think about, what have you got in your local unit that helps you cope with busyness and with stress, apart from your wonderful teams. And I hope you are working in a wonderful team. Now, I'm also got to remind you that, because the Maternity Midwifery Forum always copy everything, we always have everything recorded. So if you miss anything, or you really enjoy tonight's session, which I think you will, you might want to just access some more of the materials that we have. And we have quite a lot of sessions on record, some from the festivals and a lot from the maternity and midwifery hours. And it's all very accessible, all free through Matflix, and it's on your resources sheet, which is available online now. And you can share it. We're very happy for you to share. And you can also use it for revalidation for those of you who are midwives. Maybe if you're doing a project for an assignment, or at university, there's loads of material you can access. The only health warning I would give is it's a bit addictive, because once you get into looking at some of the materials, it gets really interesting, and suddenly a couple of hours has gone by. So enjoy. anyway, enjoy that sort of addiction. It's a good addiction. Now, I'm going to say a big thank you to our midwives and our student midwives and all the people in the maternity services providing care to mothers, babies and their families. Really important work. And it's really sincere thank you, because we know you're working hard. And it can feel as though nobody's kind of recognizing that work and your value. And we do recognize that. Now, I'm on to my news feature, which is a quick flash through the news. Now, the APPG report, birth trauma report, is still on your resources sheet. Here it is. It's only 80 pages, and it's well worth reading, because we need to know what has gone on, what women are reporting, what families are reporting, because that way we can really address and get better at what we do. So that's another bit of your homework for you. But there's a new report that I came at. I'm a Twitter girl, me, and don't give me no X. It's Twitter for me. There's a new report from the Letby team, and it's called the Thirlwall Inquiry, and it's a review of the implementation of recommendations for all of many previous inquiries into healthcare issues, and it's very interesting. And again, I haven't read the whole thing and don't press print, because it's 800 pages. So make sure you maybe download and read it like that, because it's a lot cheaper than printing out 800 pages. But it is very interesting to map the recommendations that have been made, because this Thirlwall team have really looked carefully at the recommendations all the way through. And you will find, and if anyone's doing anything researchified, this would be very useful for you to track through recommendations and whether they're picked up and whether they're not picked up. And if they're not picked up, why aren't they picked up? So that's more bedtime reading for you. Also, today is the UN International Day of UN Peacekeepers. And gosh, we could do with that. In this world of turmoil and wars, it's dreadful. We need more peace and love, that's for sure. It's also still Maternal Mental Health Month. I also want to say big congratulations. We have the Fellowship of the Academy of Medical Sciences, and that it was announced yesterday. And I want to really acknowledge and congratulate Professor Jane Sandel of King's College London and Professor Shakila Thangaratinam from the University of Birmingham, who's also studied into maternal health. Also, just to highlight, there's a WOW, and that's Wellbeing of Women / RCM entry-level scholarship. And this is worth, you have to apply for it, but it's worth potential £20,000 for a year to support studies, usually university level, obviously. Submission date is 11th of July, and it's worth looking at to see if you meet the criteria. And these are all on the resources now, so that's well worth having a check on. I'm also highlighting, now you might have noticed a fancy QR code and an infection control survey that came up while you were waiting to come on to the hour, and it'll be coming up after the hour. And we're looking for people to complete this survey. It only takes 4 or 5 minutes, literally, and it's all confidential. And there's a risk or a potential to win an Amazon voucher, so it's worth having a go at. So you just flash on the QR code and it'll take you through to the survey. Worth doing. So if you haven't done it, please do. Okay, now, gosh, I'm almost perfect timing here now. We're going to this week, we're going to be looking at record keeping, and you might be thinking, oh, well, we know all about that. I think you're going to find you don't necessarily know everything about it, and it's worth thinking about strategies to make us better at doing this. This was very much in response to one of our lovely participants who wrote in and said, is there a way that you could talk about record keeping? Because I'm finding it really difficult. Are there any strategies and sort of frameworks to use to get used to doing this? And this was a fairly newly qualified midwife, and we thought, let's look at something like this. So we're delighted to be, we're joined by the motivational midwife. Lyn Jones, our lovely Lyn Jones, and she's an associate lecturer at Anglia Ruskin University. She's very experienced midwife and a midwife teacher, and she's focused very much in her whole practice in improving women's experience of maternity services and babies, obviously, because she's got extensive experience with examination newborn. And she's also teaches on the pre-reg BSc in midwifery, and obviously with her motivation midwife. And if you haven't accessed Lyn's YouTube sessions, it's well worth doing that, because she's got some lovely, lovely sessions, which I'm sure she'll refer us to this evening. And she's going to kind of introduce not all the answers, but some of the questions we need to have, some strategies, and some of the difficulties that we have, because we've been discussing this earlier about the good old days when we had paper records, and you kind of, people either wrote screeds and screeds and screeds, or just said admitted SVD at such and such, baby's fine. And I'm sure some of you will remember that. And things have moved on a bit, but there are difficulties with the new systems as well as the old systems. So welcome, Lyn. Thank you so much for coming this evening. The screen is now yours.
Thank you. Thank you very much. And thank you, everybody, for having me. Documentation is something I do feel quite passionate about. And my whole career, I've been lambasted for writing too much in notes. I'm not sure you can ever write too much, and hopefully the reasons for that will become clear as we go through that. I've entitled this Negotiating the Minefield because it is a minefield. There's no kind of one size fits all anymore, despite what you're taught in universities. So to begin then, it is a bit of a whistle-stop tour, because I'm very aware that I have got a limited amount of time and I could talk for England, believe me, I could. What governs us? And you'll all be very familiar with this. I mean, data protection, obviously, we have to adhere to. For us as professionals, and the things we're probably most familiar with is the code, and perhaps less so for older midwives, the standards for proficiency for registered midwives, because they came in 2019, and kind of, if you've never really looked at them, definitely have a look at them, because they are an eye-opener of the standards that we are expected to achieve now. It's not just one or two, there is loads in there. And less commonly, but we don't always think of the International Confederation of Midwives, but actually they do to some extent govern us as well. A lot of what they, certainly I'm trying to think of the word, the definition of a midwife comes from the ICM rather than anywhere else. So looking briefly, and I'm not going to read all this out to you because you can read, I'm sure. But point 7 says we need to communicate clearly. And that in itself often has problems, not just for verbal communication, because a lot of people now, we're in a very, very multicultural society, very multicultural. And certainly the area within where I work, I think there's something like 90 different languages spoken. So interpreting services are used frequently, and I suspect I should be using some tomorrow because I've got a booking clinic. And that in itself makes a problem for documentation and also communication, because however good the interpreter, unless they are a midwife, you're never quite sure that they're actually interpreting what you are interpreting, asking them to interpret. And equally, you're not sure of that person's understanding. And part of this, if you look at 7.4, check people's understanding from time to time. And how easy is that to do when you have a non-English speaking client? It is very problematic. My personal practice, and I know it uses quite a bit of paper up, is I try and use Google Translate to translate information, so I can give, as well as the interpreter, I'm giving the couple a paper copy of the information as well, just so that I can be sure, particularly around things like screening tests, blood tests. These are things that we are asking for informed consent. And if you are not sure that they actually understand what you're asking, how can you be sure that they are giving informed consent and not just saying yes? So it is very important that we really use that range of verbal and non-verbal methods to actually really get to grips with, do people understand what it is we're trying to ask of them? Keep clear and accurate records. This, I think, is extraordinarily problematic in these days. The NMC say that we, and it'll come to it, that our records should be contemporaneous. That means written as close to the event as possible. Now, I'm sure many of you are the same as me, that you're no sooner finished a birth, and you're barely got your records kind of in some sort of shape, and you're being asked to take another lady. So sometimes it's quite, there's quite a period of time elapsing before you're actually documenting the care, perhaps for the first person you've looked after. Now, if you've had someone come in, they're in advanced labour, you haven't even had chance to get things open, you're scribbling things on a piece of paper, what you may not realise is that piece of paper is your contemporaneous record, not what you transcribe into your notes, but that actual physical piece of paper is your contemporaneous records. And as such, that's the piece of paper that should be scanned into the notes if it's electronic, kept in the notes if it's paper, because that is your contemporaneous record. And it's very easy when you're tired and you're being asked to do a lot of things to actually mistranscribe things. And if you have got rid of that piece of paper, your contemporaneous note has gone. There's no way of going back on that. Okay, we do need to, obviously on this, it does say about storage, not making things up. And you might think, surely nobody does that. But I can tell you, when we had supervision and I was a supervisor, I actually had to take a midwife to the NMC for falsification of maternal observations. Now, I don't need to tell you that potentially that could have been catastrophic to kind of make observations up. Fortunately, there was no poor outcome and it was purely by chance that it came to light when the mother complained. So, although I'm sure most of you would look at that and think, surely nobody doesn't write things down accurately. Surely nobody falsifies records. Sadly, people do. And I often think that maybe some of that is down to the pressures that everybody is under these days. So keep our records securely. This is even more tricky, I think, now when we are electronic. Most people, I think most people I've come across now do have sort of mostly electronic notes in some way, shape or form. Women have access to those notes, but other people might have access to those notes if you're not careful, if you don't, if you leave computers open at a desk with people's notes on. Remember that, again, it's very easy to do. You're halfway through writing something, the phone rings, you've got to send, give a message to the midwife in charge, your screen's still open, you've left your desk for a moment. That information about that person is actually on display to whoever happens to pass that desk. So you do need to be mindful about shutting locking your screen if you're going to be away from it. 6.4, I always think, is an interesting one about clearly documenting the woman's understanding, input and decisions about her care. Now, I don't know about you, but I very rarely actually see anything written in anybody's notes about her understanding. I see lots of things about what we've discussed, but not necessarily about what her opinions are on it and what her decisions are about her care. And we have to accept, and this is in the code as well, that our job is to give evidence-based information so that women can make an informed choice, or birthing people can make an informed choice. If they are quite within their rights to reject our information, what we give them, and reject our advice, they don't have to say yes. And I'm sure all of you will agree with me that when women do this, we're very good at browbeating them into submission a lot of the time, into coming round to what our way of thinking, because that's what we need them to do. We need them to comply with the blood tests or the scans or the vaginal examinations, or without really thinking, actually, is this evidence based what we're asking of these women, or is it just actually what we need to get through the day? We just need to get, I mean, vaginal examinations is one of my bugbears because it is not a particularly useful, well, it's a useful tool, but not in isolation. And we are very, I think it was Rachel Reed that coined the term cervix-centric. So we are, as a nation, not just as professionals, very focused on the cervix and how many centimeters it is. Even the women are very, very much like that. But it's a very small part in a big picture. And if we're not careful, we're losing our midwifery skills about how to actually diagnose labour without poking women around. And when you get a woman who actually says, no, thank you very much, I don't want to have vaginal examinations, the eyebrows that raise are unbelievable. And, you know, I've had midwives in charge saying to me, well, what is she doing? Is she doing? In fact, only this week had said, poor midwife, saying to me, well, what's she doing? And I said, she's in labour. Yes, but, you know, how many centimetres is she? I said, I have no idea. I haven't examined her. She doesn't wish to be examined. She is labouring. And sure enough, within about the space of 5 minutes, she birthed. So, and was thrilled with her care. It was her third baby, and she was totally thrilled with everything, that she'd been given the option to make choices about whether she had or didn't have certain things, albeit that was all happening quite quickly. And then our ICM says very much the same sort of thing about complying with local regulations and the law in our country. So for us, this would be data protection and ethical codes and NMC codes. So why is it important? Well, for us, it's a legal and professional requirement. And you might think, well, yes, it is a legal requirement. And certainly in the days when I trained, it was pretty much drummed into you. If it's not written down, it didn't happen. And to some extent, that is true. And what I would like to sort of really stress is your documentation is really helpful to the woman. If in the unfortunate event that something doesn't go quite according to plan, unfortunately in this country, these families have no other recourse but to sue us to get money to care for their child. They don't have a choice. And your documentation can either help or hinder that process for them. And that's not to say you're putting your hand up and saying, yes, I did this wrong. It's about being honest and truthful about what's going on at the time and writing that in the notes. From my own example, one of my daughters suffered a 4th degree tear after her second baby, which was completely avoidable. But when we actually got the documentation, her documentation was a series of tick boxes and bore no resemblance whatsoever to what happened in the birth room. I've also had to give evidence in a coroner's inquest before now. And I only looked after the lady for an hour, but I was in the box for 2 hours giving evidence on that hour. And my documentation was such that I was able to answer every question, even though it was well over a year after the event. But I was able to answer every question that was put to me because my documentation was such that I could answer these. Now, if you haven't written full explanations of what's going on in a room, and you are called to give evidence in a legal capacity, or even just within a well, I can't think of the word now. If there's been a serious incident and they're just investigating it within locally, you will sometimes be asked to give a factual account of what's happened. If your notes will help you give that factual account, assuming that you've actually written accurate records at the time, so they can help rather than hinder. It also gives a full picture of the care that's been provided to that woman. Now, this is extremely important, and particularly with the whole advent of the whole birth trauma report. In your various trusts, you may have something called like birth afterthoughts or birth reflections, debriefing services for families. As I'm sure Sue has over the years, debriefed many families, and sometimes years after the event. And when you're looking at the records, tick boxes actually don't tell you what was going on. They tell you the tasks that were performed, but they don't give you the story of what was going on in that room. This is where your free text, in whatever system you are using, there's usually a capacity for you to free text things. And that gives you the ability to actually add those extra bits in. You know, so how is she coping? What strategies have you put in place to help her cope? You know, what is her concerns? What have you suggested to her? All of those things that you can write in that free text that gives that full picture of the care that was provided, rather than ticking the box, cup of tea given or refreshments given, car parking given, resuscitate checked. You know, they are very task focused. They don't give you the picture of the care that was provided. And that is really crucial, I feel, when you are trying to debrief families after the event. And sometimes they need debriefing, even if everything's gone swimmingly well. I have in the past debriefed a lady 5 years after her. She was pregnant with her next baby and she'd come for a debrief. And I looked through her notes and I could not see anything that made me think, why was she so traumatized by this? And it turned out that, you know, right near the end, the fetal heart had decelerated. She'd been transferred from the birth unit, delivered her baby very quickly on the delivery suite. And nobody, when I was going through all the notes with her, and I went through the CTG with her and pointed out all the bits and said, oh, and looks like your baby had the cord around her neck, and that's probably what caused that. And she said to me, I'm sorry. And nobody had spent that time just saying to her, that's probably what caused it. It's, you know, not that uncommon. And she's had 5 years of trauma and anxiety. So it does, you know, it's really important that you write all those things down, because if somebody hadn't written cord around the neck in the kind of story bit, we wouldn't have known that, and she still wouldn't have had any good reason, you know, that I could find in her notes for why she was so traumatized by it all. Record keeping is really important for your multidisciplinary team working. Who's doing what, you know, what is the plan? What is the management plan? What if they've been seen by obstetricians? What was the outcome of that? You need to be able to access those so that you can get a good picture of what is the care plan for this particular pregnancy and birth. And sadly, because of litigation, which we have already touched on, so I won't go back into that again. So types of documentation, the most common for us is our clinical records, which are either paper or electronic. You can have minutes of meetings, you can have various pro formas, you can have charts like your observation charts. For my current practice, both trusts that I work at are electronic. Some of the issues I have with electronic documentation, apart from the fact that it's very tick boxy, is that it can take your care away from the woman, particularly in labour. Now, when I had ran the birth unit, I used to be, and I had paper notes. I could get on the floor with my piece of paper and my pen, and I could still be with woman on the floor writing my notes, and still be very much in contact with her. That is much harder in one of the trusts I work in, because the computer is kind of on wheels, it's up in the air, and you become very, very focused with that screen and making sure you have done all your fresh care and your fresh eyes and your all of these things that you have to do while you're caring for someone in labour, that your focus can be really taken away from the person that is in your care. The other trust I work at have iPads. So yes, you can get back on the floor. But the problem I find with the iPads is I have nice big fat arthritic fingers, and so it's quite difficult to type on an iPad, free text, and plus the actual platform they use, I find quite challenging as well. I'm sure I'll get used to it eventually, but that makes it a challenge. Even though I can be closer to the woman when I'm doing it, your focus is still very much on that computerized screen. So the systems, I was saying, computerized. So Badgernet, K2, Epic. I'm sure there are others across the country. They are not the same. I mean, ideally, it would be lovely to have exactly the same system throughout the whole of maternity services. That you'd kind of think would be sensible, because we'd all then at least be singing from the same song sheet and we'd be filling the same things in. It would make it less traumatic for people, particularly when you're going from trust to trust. As I say, I work with a K2 in one trust and Badgernet in another, and I find they're both completely different systems, and both of them have pluses and minuses to using them. And obviously paper. Big fan of paper, but that's probably my age. So things to consider as well. Women have access to their notes. So you need to think about what you're writing. Gone are the days when, and Sue will remember this, when you used to write things like FLK, funny looking kid. You have to write things, you have to be correct. You can't write things like that. And I mean, you shouldn't have been writing them anyway, but certainly it definitely happened. They definitely used to get written odd things in people's notes. You need to be mindful if you've got safeguarding issues, that you're using confidential modes when you're writing things in notes, because again, if you have perhaps domestic abuse, the partner may be accessing those notes. So you need to be mindful about what you write and what there's access to for things like that. If you're transferring to another ward or unit, they don't have the same system as you. So do you need to think about printing off your records so that the woman can take hard copies of anything with her? Even interdepartmental access is a challenge. Because K2, certainly at one trust, is within the maternity department, but it doesn't exist outside the maternity department. So if she was going to be seen in A&E, they wouldn't necessarily have access to anything that's gone on before. If she was on a medical ward, they wouldn't have access to anything. Our GPs and health visitors don't have access to a lot of those computerized systems. Think about your students as well. It's really important that you, as midwives, are actually teaching the students how to document. That it's important. I mean, I actually had a lovely comment from a midwife who's been qualified quite a few years now, and she was one of my students. Our systems actually in one of the trusts completely crashed for a weekend. And the amount of people that suddenly said, I've forgotten how to write. I've forgotten what to write, because they have become so used to ticking boxes and using wizards to complete checks and all sorts of things that they'd forgotten how to write. And this midwife said to me, I can still remember how to write a vaginal examination up, Lynn, though, because you taught me, which I found was quite amusing. Don't forget as well, if your students are documenting, that you have a duty to countersign their documentation. And some systems, like the K2 system, within the labour area, there is a button on there that you can, a mentorship button that you can tick and put your fingerprint on, so that will countersign. But outside of that, so the antenatal and postnatal bits doesn't have that facility. So I have to go in and free text and say all documentation by student read and agreed, and then sign it. Otherwise, I haven't actually countersigned her documentation, whereas if it was paper, I would be countersigning it. So just because it's electronic, just remember that you still have that duty. You are ultimately still responsible for that woman's care, even if your student is providing the care and the documentation. You, as the midwife, you're the one with the pin, you're the one with the registration. So you do need to be very careful that you countersign everything that they have written. So thinking about the different periods and some strategies that you can look at. So over the last sort of couple of years, I've been quite heavily involved with preparing the international midwives for their NMC OSCEs. And part of their OSCE is they have what's called an API station, which takes the best part of an hour. And they have an assessment station, a planning station, an administration station, so an implementation station, which is essentially a drug administration station, and then a evaluation station. So this kind of very much looks at using an SBAR, situation, background, assessment and recommendation framework to do an assessment on someone. And they could get any sort of scenario. It could be antenatal, it could be intrapartum, it could be postnatal. So the framework is exactly the same. But so although I put booking here, the little analogy we use, acronym we used to try and get history out of someone and that background was SOMAD. And because sometimes you get so mad, you've just got not enough time to do anything, and it kind of it stuck with them. So when even if you've got someone coming in labour, you've got someone you're seeing in a triage area, what is their social history? Have they got a partner? How are they living with somebody? Are they supported? Do they smoke? Do they have any of those? Do they take illicit drugs? Is there anything in that social history, children's social care involvement, any of those things that might be an issue? And O is for obstetric. Okay, so what's this past obstetric history? What's this current obstetric history? Are there any specific problems in this pregnancy that you need to know about? What's her medical background? Has she got any underlying conditions that you need to know about? Has she got any allergies? And is she on any drugs? Is she on any medications? So if you kind of think about SOMAD, in a very short period of time, you can elicit quite a lot of information that you can put into your sort of situation and background boxes of your SBAR handover. Management plans are another thing to look at and put. So very often when I do a booking, you start a management plan. So what is the plan at that point in time in booking? Is she a low risk pregnancy, in which case you're writing down basically some of the SOMAD details, the salient highlights in that management plan, and what's your plan going forward? If she's a higher risk pregnancy, what's your plan going forward? If she's been seen by obstetricians, look at the management plans that have been put in place, because they will guide you as well as to where you need to go. Is there safeguarding issues? Have you addressed that? Risk assessments, we are very, very risk averse now in the NHS, and I'm sure that all of your systems, whichever you use, are equally as lengthy as K2 in the risk assessments, because you've got risk assessments for VTE and fetal growth restriction and PPH and there's a gazillion risk assessments that we're doing. We're not, as I say, we do these risk assessments and we don't always think when we're doing them, have we given that woman informed choice about where these things might go? And I think specifically of things like VTE. And I'm a huge fan of Sarah Wickham. If you have not read Dr. Sarah Wickham's books, I totally recommend them all. Her latest one, Plus Size Pregnancy, very much looks at BMI, and it's a big eye opener when you read it as well. But she's already done all the hard work for you. She's looked at the research around VTEs and all of these things. And she actually, in one of her blogs, had said about informed choice, and she'd said, do we actually tell women when we do a urine sample on them, if we send it off, that if it comes back with GBS, that's going to very much curtail her pathway in labour? And I have to say, I hold my hand up. I never did. I take the urine, I dip it, and I say, yeah, we'll send it off, make sure there's no infection in there. But I hadn't followed that up with, if this was to come back with this, it may have implications on your pregnancy journey. Never even gave a thought. And I thought, so am I really giving this woman informed consent, choice? And I thought, no, I'm not really, because she could quite happily say, no, I need to decline that. So I'm aware time is marching on. So intrapartum, some of the things we're obviously documenting, it's important you're documenting your observations, both maternal and fetal. Don't just document them though. If you're on an electronic system, it very often will have a meows chart there, but unless you look at the meows chart in its entirety, you cannot see a trend. You will just see that set of observations is kind of normal. That set of observations is normal. But when you look at the meows chart, you might see a rise in something, and likewise with the partogram. If you don't look at it in its entirety, you will not get that sort of developing trend that's going on. So please do look at those. And again, the story, the free text, write in what's going on, what's been happening. Postnatal, again, have that holistic top to toe approach. If you always start at the head and work your way down, whether you're antenatal, postnatal, intrapartum, you are not going to miss anything out. Put your plans in place. Think about the baby. What does the baby need? Are there any specific things you need to think about? Your documentation around the baby, feeding advice, feeding support. And so very quickly, as I know that time is marching on. So make sure, your notes are as contemporaneous as they can be, that they are accurate, that you date and time them, that you sign them, you countersign your students, and if they are paper records, that they are legible. Electronic, I have to say, I become very dyslexic when I'm typing. And some of my spelling is atrocious when I look at it. And I'm afraid on some of them, I'm pretty much shouting at everybody because everything's in capitals, because I can't do this swapping from lowercase to uppercase. So it's either all one thing or all the other. So thank you. I hope that I could go on for hours, but I won't. So thank you all very much.
Thank you, Lynn. That's fantastic. I think one of the things I'm taking out from this really strongly is the importance of the story, because, and I think that's for midwives, that's very strong, because we do, as practitioners, operate very strongly as sharing stories, don't we?
Yes,
and
we
women
do.
themselves, if you ask them about their previous birth, they'll tell you the story, and it's really important to them. So thank you for really highlighting that, and also looking at the whole, because that's, and I was thinking of a particular situation where a mum, the person was taking the observations beautifully, plotting them all, and didn't notice that the pulse rate was going up and the blood pressure was going down, and that had big implications for that woman, actually, ultimately. So that was really seeing the whole, and the whole story was lovely. So thank you for that.
And when we had paper, that was easy, Sue, because you could
yes,
see it on paper, but you can't always see it so easily on electronic systems.
No, that's true. That is very true. And I think that's what we're having to deal with. And you kind of think we're all going to be trundling around with our little computers. It's much harder. And we had this discussion, didn't we, Lynn, about being able to touch the woman and sit down with her. It's much easier to tuck yourself behind a little computer screen. And I know that happens in all sorts of areas of healthcare at the moment. And I think we need to buck the trend a bit here. Anyway, we have some comments and questions, I think, coming through. And we have a comment from our Jenny Hall. Hello, Jenny. And she says, something to remember in legal cases, it's that notes and events are time specific. E.g., we used to throw CTGs away as they weren't seen as useful. I had a legal case that was 22 years old. Whoa. Thankfully, my notes were contemporaneous for the time and could remember what we did in practice. Actually, that's really useful, Jenny. That is really useful. Fantastic illustration. Okay, and then we have now Awa has beautifully summed it up. Awa Hadid, hi Awa, and she says, yes, how could we be with women when we seem to now be with computers? Now, have we got an answer, Lynn?
No, is the short answer. I mean, unfortunately, it is the way of the world. And I think because healthcare has become very, very much focused on audits and data collection, that yes, computers are very useful for getting that data quite quickly. But the downside is it does, I feel, quite strongly remove us from that sort of personalized care. And you really have to think about being with the woman and not spending so much time at the computer. It's, you know, it is a challenge. And I certainly will say to women, I'm so sorry, it looks like I'm on the computer a lot. But I will try, even if I will try and have the computer as close to the wherever the woman is as possible. That's helpful. And also I will try and sort of, depending how she is, I may stop what I'm doing on the computer to focus on her. Particularly if she's in labour and contractions are happening and things. To be fair, with postnatal things like postnatal checks, you should be able to do a postnatal examination without a computer by your side and then fill it all in. You should, you know, I mean, I've always said you should be able to do an antenatal and a postnatal in the middle of a field, you know, and then you put your information into the computer. You don't really have to be able to type it in as you're going with the postnatal examination. It's slightly trickier in labour, but yeah, it is.
Yeah, I was just envisaging when when you were talking about contemporaneous and record keeping and how you have to keep your piece of paper, and I was thinking, well, in days gone by, the paper towels was something that were quite commonly used.
Totally.
And I had a picture in my mind of a whole bunch of notes or a computer with lots of paper towels scanned in. Because of course you're right, is that's contemporaneous.
That is the contemporaneous note. Yeah. And I remember it was quite a few years ago, and when supervision still existed, and I did do a litigation-y course for supervisors, and I asked this question. And that's when they said, but that piece of paper is the contemporaneous note, and therefore that's the one that should be kept. And although it's discouraged writing on bits of paper, sometimes you have no choice because you can't necessarily, you know, if you have someone comes in, particularly in advanced labour, or comes in and there's an emergency going on, you may have to make those first few initial documentations on a piece of paper. Otherwise, you'll forget them.
I mean, the other thing is we can use our colleagues as well, because if you can't take the records yourself, your student can do so, or your student can be providing the care and you could be doing the notes.
Yes, so if you've got that facility and you've got scribe sheets and things, that's great. But as I say, I think the most times that I often probably in my own practice have used the piece of paper is those women that come in advanced labour, and you're listening to the FH, and they're the things you're making quick notes about, rather than because most places now have scribe sheets and things, don't they, for emergencies.
Okay, well, we have someone called Cheryl Eady, and she says, hi, Lynn.
Hi, Cheryl. We saw each other the other day on mandatory training.
Wonderful, wonderful. See, this is just like a big midwife chat. Fantastic. We've got another comment from Ali Kelly, and she says, as a third year, I've had to ask midwives to countersign my notes.
Yeah.
To be fair, I think, Ali, I think sometimes we all need to be reminded. Yes. And sometimes if you're a fantastic student, they might forget you're a student and you need your work countersigned. So be patient.
And again,
as I say,
it is trickier with electronic documentation. It was much easier when you had paper notes and they were being stuffed under your nose and you just had to scribble your signature.
Yes, so much easier. Okay, we've got another comment, and that's Awa again. Thank you, Awa. She said, I used to love reading the birth story with written notes. The handwriting of each midwife is very personal, although sometimes computer written work is a godsend when trying to decipher the hieroglyphics of some of our colleagues.
Definitely.
Awa, that's lovely. But
Definitely.
but that does sum up the story bit of it. So thank you for
Yes.
Awa for that. And then we have Juliet Samuel, who's one of our regular, like Awa. Hi, Juliet, and in Essex. And she says, where do we find the middle ground? Making the balance appears challenging when we were told the IT stopped us waffling, yet now there are obvious gaps that fail to elicit conversation. Can it be reclaimed?
I think it can, and it's back to that free text. Use that free text um, to reclaim. I mean, I've never stopped writing reams. I just write it in the free text. I'm
Mm.
not necessarily the best one at completing all the wizards that they like completed, but there's a lot of my care is in that free text, in that story. So I think yes, you can. And you will always get people that will lambast you for writing too much. But as I say, from my own experience, and certainly that first comment we had about her 22-year-old case, you know, her records stood her in good stead that even after 22 years, she was able to take herself back into that room and know exactly what she did. Now, I'm not so sure many of us could do that on the computerized records.
Mm.
Just, you know, if you haven't written that story and you are in, you know, a courtroom or a coroner's inquest and you're asked to recount what was happening in that room, it's your records that are going to aid you to do that. And we are all, despite how it seems to be getting eroded, we are autonomous practitioners. So we have to take, you know, despite what the trusts tell you about, you know, you've got to stop being waffly and whatever, it's your practice, your accountability. So, you know, I don't care if I'm waffly. I know that and I have proved that if I am standing in a coroner's court, my records will stand the scrutiny. And they allowed me to answer every question that was posed to me, you know, even well after a year after the event. So it, I feel, you know, you have to be true to yourself and write what you feel is appropriate that will help you if you were ever called to recount what happened in that person's whatever part of her antenatal, intrapartum, or postnatal journey. Would you be able to do that from your records?
And I think that's a useful kind of check on yourself, isn't it? To think, would I remember this in a year's time? Will I remember this woman and her
Well, I'll remember
baby
it in a
in a
week's
year's
time,
time?
never mind a
Yeah,
year.
well, exactly. And I mean, you have to also remember that it's those busy days when you may not remember everything, where things can be dropped or forgotten. So it's worth just checking in and maybe doing a bit more writing than you would normally. And I think Lynn is a very good role model here. I know I was trained to write a lot. I always write a lot of records, and I think it's nice when you can look back and see, yes, I remember that, Mum, and I can remember doing that, because it's especially an issue for litigation because of course, though they use the sort of it's the bolum, isn't it?
Yes.
That you look at what the average person would have known at that time. Your practice is gauged by the textbooks of the time. So all the legal people will have the textbooks. If it was 1986, they'll have those textbooks. But you know, you need to kind of have your own records in yourself.
Yes, definitely.
Now we have got some more here. We've got a comment from Emma Turner. Hi, Emma. And Emma says our digital team's goal is to make things as quick and easy as possible so we can get back to the pregnant persons. And also it's so important to explain to them why we're documenting and involve them in what you're doing. I always say you can't write or type and help birth a baby, so it's never completely done in real time. Maybe one day we can ask Alexa to document everything for us. Well, as long as you have to speak very, very clearly, or you might get something else than you're expecting, of course. That's lovely. Thank you, Emma, for that. Alexa, birth that baby for me.
I mean, there
Je-
are systems that they use in university, isn't there, for people that
Mm,
have got, um, dyslexia and things.
dyslexia,
They have
yes.
little pens that record
Yeah,
the
yeah,
speech to text things, and I do think that that might be a slight way forward.
yeah.
Although I know we were talking about this earlier and said my only concern with that is that if everything's being actually recorded, would we then become very quiet
And not
because we're
towards the
very
poor
aware?
mum.
Yeah, we're
Yeah,
very aware that we are being recorded then.
absolutely. Well, that's the bad side of it, isn't it?
Mm.
Okay, we've got Jenny Hall back again. Hi, Jenny. She says, can we get women to complete their own notes as much as possible? Then you can discuss what they've written. No, that's a nice one.
We used to do that, didn't we, when
Mm,
we had paper notes?
yeah. And then we've got R. This is a comment again. Sometimes I've needed to ask students for the notes so I can countersign them and check what they've written. So
Yes,
that's the counter thing
yes,
of
to
the
Ali's.
student.
Yeah.
Thank you for that, R. And R
And to be
also
fair,
says,
we should be reading what we're
yeah,
countersigning.
yes,
Also, you,
absolutely. Oh my God, dyslexic. I'm a dyslexic midwife and have a love-hate relationship with both computer and handwritten notes. So love bullet points on both to make my reams easier to read for myself and other colleagues. Good
mm,
point. Whatever
yes,
works, whatever works.
totally. I mean, I don't think it matters if it's bullet points as long as you have all the key things in there.
Hmm.
Um,
This is the answer.
yeah,
Okay, and we've got a comment from Emma Turner again. Hi, Emma. And she says, I'm an advocate for both the tick boxes and also the free text boxes, as the tick boxes are so important for audit reporting and submitting data for Ockenden, stroke SBL,
mm,
etc. And the narrative is the story of the care you give. The story is why you tick those boxes. That's
yes,
Emma, that is beautifully put.
very
Beautifully
nicely
put.
put. Yes.
Thank you for
The
that.
sad thing is, though, Emma, that unfortunately, lots of people tick the boxes and not so many write the story.
Mm, yeah. I mean, I guess, yeah. You just you almost think you want to sort of write an account that's not in
Mm,
the records, but of course then you've
yes,
got to take care of being very anonymous, etc., haven't you?
yes, yeah.
Okay. And Jenny Hall again has said, can we get women to write their own notes antenatally and then use them for discussion?
Good thing.
Yeah, all of those things and above.
Although a lot of the notes now do have, albeit that they are electronic, they do have like personalized care and support plans in there where women can access and start, write down, their thoughts and views on that and
Mm,
start being more involved with their care.
mm. Well, that feels very much more about partnership working,
It
which
does.
feels really
Yes.
lovely. That's what we should be working for. Now,
Yes.
now I'm coming to the end of this hour, and I always say this hour is the quickest in the whole week, and it's gone really, really quickly, and it's been
Has gone
lovely.
very quick.
It's been lovely listening to Lynn because she's giving some of the tricky bits and some of the kind of history bits and some of you in some of the countries that you're joining us from are probably still using paper. So I hope that's been very useful for you. Some of us are using computers, some are a combination. I think Lynn's picture of being able to do a postnatal or antenatal visit in a field and be
Mm,
able to manage it is absolutely appropriate, because we need to be able to do that because we are very practical people, and the care we need to give is very practical. And we might have in the future computers, and we might have Alexa and be able to say, Alexa, record this, do that, the other. But at the end of the day, we can't lose that with women that
mm.
we have, because that's part of what makes us tick. Now, so I'm going to bring us to a conclusion. I'm going to say huge thanks to Lynn for
Thank you.
joining us this evening.
Thank you.
Also, I'm going to say thank you to Angela in the background, making sure it's all recorded. So if you missed anything today, you can get the recording tomorrow. Also, you might find it useful to share with other people and have a discussion together about it, especially if student groups or midwife groups, if you're doing your revalidation, really handy to do that. thank you to Paul, who's fed the questions and comments to me. I have to say, what a fantastic group of participants we always have, and even better tonight. Fantastic. Thank you so much. Now, I'm going to say, for those of you who want the podcast at 6 o'clock in the morning on Friday, it will be there waiting for you. And I'll also just remind you to check out that antiseptic survey, the infection control. If you haven't tried using a QR code before, this is your chance. It's still quite new for me, but I really think it's very magical. You start off with this little picture and then suddenly you're on a different website, which is fantastic. So don't forget to book for the Northern Festival on the 18th of June if you haven't booked. Because remember, if you can't make it, you'll get the recording. That's the way the Maternity Midwifery Forum always works. I've got jotted up, I've got all my little notes. This is for my revalidation. I've got paper towels and always free text. I've got all these notes I'm looking at beautifully. Now, next week, we're going to look a little bit at the birth trauma report, but also what we're doing. And we're being joined by our usual two people, and one will be Sarah Milnes, who many of you will have met before, which would be lovely. So same place, same time, next Wednesday, 7 till 8. And in the meantime, take good care of yourselves. Thank you again to our lovely Lynn, our motivational midwife, and isn't she just so? And we'll see you next week. Take care.